Good morning. I'm Angelo Avogaro. I'm the first author of the recent publication that you can find on Lancet Diabetes Endocrinology, which title is Incretin and the Cardiovascular System, Bridging Digestion with the Metabolism. Well, I think that the original idea that leads to the writing of this review is that we wish to make us understand why a hormone produced by intestine has such a positive effect on cardiovascular system. And we all know that incretin, especially GLP-1, but also GIP, has the ability to stimulate insulin secretion induced by hyperglycemia. GLP-1 is also inhibiting glucagon, while GIP is increasing glucagon. And obviously, incretin play an important role in obviously digestion, but not only digestion. Teleologically, they are committed to set the stage for an ideal oxidation of substrate that comes with the nutrient. So in the end, as for insulin, which is a vasodilator, in order to bring oxidable substrate to peripheral tissue where they are oxidized, you really need a healthy cardiovascular system. Otherwise, you don't have a proper oxidation. Just for an example, if you have, a stenosis somewhere in the arterial tree, you don't have enough blood in order to dispose oxidable substrate. So the original idea that led us to write this review was just this one, to make it clear that incretin teleologically are secreted not only to stimulate or modify insulin secretion, but also to provide a healthy cardiovascular system in order to push substrate in peripheral tissue where they are oxidized. And this explains also why incretin promote vasodilation and improve endothelial dysfunction. You know that endothelial dysfunction is the very first alteration that then will lead to atherosclerotic disease. And there are several proof that GLP-1 acutely or chronically can protect or can prevent endothelial dysfunction. And obviously, by preventing endothelial dysfunction, you allow endothelium to produce enough amount of nitric oxide, which is the most important vasodilated compound. And vasodilation allows an ideal and excellent perfusion. An excellent perfusion allows a perfect coupling between perfusion and substrate oxidation. And obviously, this is very important also in terms of, not only limited to coronary arterial trees, but also to the brain arterial trees and to peripheral artery disease. In this context, GLP-1 receptor agonists have been shown to be particularly protective against cerebrovascular disease. I think, for example, the REWIND study in which dulaglutide has been shown to significantly decrease the risk of stroke, but also the recent STRIDE study in which GLP-1 semaglutide significantly ability to decrease the risk for peripheral artery disease or to prevent a worsening of peripheral artery disease. So I think that overall, the mechanism underlying the action of GLP-1 are very important in terms of cardiovascular protection, in terms of metabolic stress, in terms of ischemic event. Obviously, this is not limited to cardiovascular system, but GLP-1 receptor agonist and double agonists such as GLP-1 GIP receptor agonist as tirzepatide has the ability also to protect the kidney. And we now have consistent evidence, like in the FLOW study, that semaglutide not only abate the risk of renal endpoint, but also decrease significantly the progressive decline in GFR, which has been observed in the people randomized to placebo. It's not clear at the kidney level whether the action of GLP-1 is either directly or mediated by an improving, at least in diabetic patient, in metabolic conditions such as significantly decline in HbA1c. But I think this is an area of intense research and should be better clarified. In our review, we highlight also the role of GIP, glucose insulinotropic peptide, within the adipose tissue. As it is known, adipose tissues does not express GLP-1 receptor, but is expressing GIP receptor. And GIP receptor has been found to increase lipid storage within adipocyte. But the situation is much more complex since GIP increased the blood flow through adipose tissues. And this has several readouts. One, for example, is to favoring the insulin effect in terms of lipid synthesis in adipose tissues, but can also modulate or increase the lipolysis in post-absorption state. Increasing the blood flow through adipose tissues, for example, is very important since one theory about the pro-inflammatory state within the adipose tissues may be related to ischemia within the adipose tissue. So the GIP effect, by increasing the blood flow within the adipocyte, would prevent, necroptosis of adipose cells, and this would prevent the pro-inflammatory state. And these are only part of pathophysiological explanation of this effect, but I think more and more questions should be still addressed to quantify precisely the interaction between incretin biology and adipose tissues biology. There is no doubt that the advent of incretin biology has been of tremendous importance, such as the introduction of gliflozin has been of tremendous importance for the treatment of patients with type 2 diabetes. And I think that now we have, to modified our approach therapeutically to patients with type 2 diabetes, in the sense that we have powerful compound that significantly improve the cardiovascular system physiology, that powerful decrease HbA1c, that improve blood pressure, they improve, especially in postprandial phase, plasma lipids, and they significantly decrease body weight. And overall, I see that, we have this compound that do not induce hypoglycemia, but they are very powerful. Yet we still, aim for value of HbA1c that are around 6.5 at the best. Instead, since we now have this option, I think that would be very important to strive to get also in patients with type 2 diabetes level of HbA1c even lower than the one the guidelines are set as a target. Why this? Because I think we have this compound that allows a consistent decrease in HbA1c without hypoglycemia. So we now must aim to level of HbA1c similar to those observed in non-diabetic humans. And this open up, to two big problems we still have in the treatment of type 2 diabetes. One, for example, is the remission of the disease, and which is, a sort of Saint Graal for patient, for healthcare professional following diabetic patient. But we also have, an important point, which is what if I keep over time HbA1c lower than 6%, for example? Do my micro or macrovascular complication would regress over time? And I think that this will be an important clinical question for all healthcare professionals involved in the cure of diabetes. And in my view, this would be a very important element for future study to set up a new threshold of HbA1c in patient with type 2 diabetes. And I hope you enjoyed the review, and I hope that you might appreciate better why using GLP-1 receptor agonist or double receptor agonist, or in the near future triple receptor agonist, you also end up with further cardiovascular protection and a life expectancy for your patient longer that we have now. And I thank you very much for the attention.